This is Dr. Chad Rappaport, and this presentation is on chronic lateral ankle instability. This is not a surgical technique video or a presentation, and so therefore we'll focus more on a review of the anatomy and biomechanics of the ankle, how to diagnose a chronic lateral ankle instability, including the imaging of such, and briefly touch on the conservative and surgical treatments of chronic lateral ankle instability. So some of the things that we definitively know is that ankle sprains are the most common musculoskeletal and orthopedic injury, with in the order of 10 to 20,000 of these occurring daily in the United States. These most often involve the lateral as compared to the medial ligamentous complex, the ATFL, CFL, and rarely the PTFL are most oftenly affected. The medial collateral or deltoid and syndesmotic ligaments are less commonly involved. We know that there's high rates of success with conservative management of these injuries, but with that said, 10 to 20% of patients will acquire instability laterally. If we review the anatomy of the ankle, we recall that the bone structure and surrounding ligaments of the ankle interact in a complex fashion. The tibial plafond and the fibula articulate with the talus, and there's stabilizing ligaments medially and laterally. Additional support to the ankle is provided by the syndesmotic and subtalar ligaments. The bony anatomy of the ankle includes the talus, fibula, and tibia. And recall the talar body is lodged in a deep recess formed by the distal tibia and the malleoli, medially and laterally. The talus is the only tarsal bone without muscular or tendinous attachments. It articulates with 4 other bones and is wider anteriorly than posteriorly, and therefore the ankle is less stable when plantar flexed. And we know that most lateral ankle sprains occur with some degree of plantar flexion and inversion. Reviewing the lateral ligamentous anatomy of the ankle, we recall the ATFL is intra-articular. It's the weakest of the 3 ligaments and is most taut in plantar flexion. The CFL is extra-articular. It's inferior and medial to the peroneal tendons and most taut in dorsiflexion. We recall that these 2 ligaments form an approximate 105-degree angle from one another. The PTFL is also extra-articular. It's the strongest of the 3 and is the least commonly involved ligament in a lateral ankle sprain. This is an illustration depicting the ligamentous anatomy of the ankle. This is an illustration medially of the deltoid complex. This is an anatomic specimen depicting the lateral ligamentous complex. Reviewing the biomechanics of the ankle, we recall that dorsiflexion and plantar flexion are the primary motions of the ankle. It's a hinge-like joint, but not purely in the sagittal plane. Dorsiflexion is coupled with eversion and external rotation, wherein plantar flexion is coupled with inversion and internal rotation. Normal dorsiflexion is 15 to 20 degrees approximately, with normal plantar flexion of the ankle joint being about 50 degrees. When someone acquires chronic lateral ankle instability, there's often a constellation of risk factors which come together to cause the underlying instability, and these can be divided, generally speaking, into extrinsic and intrinsic factors, with extrinsic factors being the level and competitive intensity of the patient's play or work, their exercise load, shoe gear, field and court conditions, the amount and the standard of play or work. Intrinsically, anatomic variations, strength deficits, primarily in the peroneal tendons, history of ankle sprains, generalized ligamentous laxity, diminished proprioception, pes cavus foot type, particularly somebody with Charcot-Marie tooth, both obviously resulting in hindfoot varus predisposing the patient. When a patient develops chronic lateral ankle instability, it's typically either of a mechanical nature, a functional nature, or one that is mixed. So mechanical instability is a sign or objective finding more so than a symptom. It invokes weakness and insufficiency or instability of the supporting structures which would otherwise provide stability. These patients have positive clinical anterior drawer and talar tilt, as well as positive stress radiography, and these patients are more likely to require surgical intervention compared to patients with functional instability. Patients with mechanical ankle instability have motion beyond the normal physiological limits with excessive anterolateral laxity. These patients typically have gone through a course or more often courses of physical therapy unsuccessfully, and the persistent mechanical instability becomes an indication for surgical stabilization. On the other hand, functional ankle instability is not an objective finding. It's more of a symptom with subjective giving way of the ankle. Motion exceeding voluntary control, but not exceeding the physiological range of motion. There's typically perineal weakness and reduced perineal reaction time. And up to 20% we find that patients have underlying subtalar instability as well. These patients have proprioceptive deficits and poor balance, and physical therapy and bracing are the mainstay of treatment. And these patients are much less likely to require surgical stabilization than patients who have mechanical instability. So when working a patient up for chronic lateral ankle instability, it's obviously important to ascertain a complete history as much as is feasible of their injuries. We need to ask these patients, does the ankle just feel weak or unstable, or do you actually have episodes of instability? And when you do, when? Is it going down declines or up inclines, ambulating over uneven terrain, etc., etc. The presence of mechanical symptoms such as catching, clicking, locking, popping can be indicative of loose bodies or osteochondral lesions within the ankle. We want to know if these patients utilize bracing or taping, and if so, how often. Is it only when they're exercising or participating in athletics or working, or do they need to wear these assistive devices all the time? Have they attempted physical therapy? And if they have instability without pain, other than directly after an episode, or do they have pain all the time? Often these patients have pain and instability, and sometimes just the excessive instability can cause pain, but more often than not, in these patients who've suffered multiple ankle sprains, there's underlying associated pathology. So beyond the examination of the lateral collateral ligamentous complex, one needs to examine the anterior lateral gutter, the retrofibular space, the subtalar joint, the calcaneal cuboid joint, etc., looking for areas of pain and associated injuries. It's also helpful to note if the patient has chronic edema to the affected side. Do they have asymmetric shoe gear wear patterns or an underlying or associated family history of neuromuscular disorders? When patients do have rather chronic constant pain, in an effort to determine where that's coming from, in addition to standard radiographs, MRIs are often garnered, much less frequently bone scans, CT scans. Selective diagnostic injections in the office with an anesthetic can be helpful. When patients do have underlying lesions in conjunction with their instability, it can be stemming from bone, cartilage, ligamentous, neural, tendon, or soft tissue sources. When examining these patients, it's best to perform both a seated and a standing examination with underlying vascular, dermatological, and neurological components, as well as an orthopedic exam that's compared to the contralateral side, noting active and passive range of motion of the ankle, the subtalar joint, and the metatarsal joints. A terminal clinical talar tilt and anterior drawer is performed and compared to the contralateral side. And any note of hindfoot or heel varus should be further explored with both muscle strength testing of the lateral compartment and a neurological exam that is often used in conjunction with the Coleman block test. When patients are noted to have an associated pes cavus or varus foot type, further investigation into the components of the pes cavus are warranted, because if these patients are obviously going to require surgery to address their ligamentous instability, it doesn't make much sense to do so without also correcting any underlying biomechanical issues. In instances where there's a high clinical suspicion of an underlying neurological or neuromuscular disorder or hereditary motor sensory neuropathy, asking the patient to walk on their heels, toes, testing their balance, and observing their gait is warranted. I put imaging here because most oftentimes these patients will undergo MR imaging of their brain and spinal cord. This is typically done by the neurologist, whom would be referred to. Here's a patient with bilateral pes cavus, quite a bit more significant and pronounced on the left side, and you can't just assume that the increased varus on the left side is due to anatomic or structural insufficiency. You have to ensure that there's no underlying neurological component. As far as imaging is concerned, I think we all start out with full weight-bearing views of the foot and the ankle, which can give us an overall idea of the patient's foot structure or foot type. It can also depict or diagnose latent fractures, osteochondral lesions, coalitions, avulsions of the perineal retinaculum, etc. These are plain radiographs of two patients, one whom on the left had worsening instability with progressive amounts of mechanical symptoms, including to varying degrees catching, clicking, locking, and popping. The patient on the right is a patient who presented with the sensation that something was moving behind the ankle. Of course, we can see a flex sign here consistent with an avulsion fracture of the superficial perineal retinaculum, which could lead to secondary perineal subluxation, which obviously is something that you would want to address operatively at the same time of the stabilization. There's a pediatric patient on the left who presented with frequent ankle sprains and pain, ultimately deemed to be due to this underlying coalition. The patient on the right was a patient with instability and chronic lateral midfoot pain. The patient on the left with a pes cavus foot was ultimately diagnosed with Charcot-Marie tooth and had a pes cavus reconstruction in conjunction with a lateral ankle stabilization. The patient on the right ultimately was treated with a supramalleolar opening myjosteotomy. It's important to include standard foot imaging so as not to miss injuries such as this. The cornerstone with regards to diagnosing mechanical lateral ankle instability lies within dynamic stress radiography, which is quick, reliable, and safe, and can be done in the office. It consists of the anterior drawer and the talar tilt, respectively. And although there are published normal parameters that you can compare to, it's often most accurate to compare these findings to the contralateral side, if obviously the contralateral side is healthy. These typically are not done in the acute setting, but when they are done, it typically requires a hematoma block. There are commercially available jigs, such as the Telos vise, to standardize these views. This is the Telos device. However, I do not have any personal experience utilizing it. These stress views can help determine which of the ligaments are insufficient, with the talar tilt being more indicative of CFL insufficiency and the anterior drawer being more significant in weakness or attenuation of the ATFL. I apologize for the fuzziness of this x-ray, but this is a normal anterior drawer. Abnormal anterior drawer. Ancillary imaging in the way of MR and CT scanning is relatively uninformative and unnecessary in the specific diagnosis of chronic lateral ankle instability, but they can be great screening tools to look for associated lesions and sources of pain. More often than not, the MR will be favored over the CT. Again, this is not absolutely necessary for all patients, but routinely ordered because most of these patients have chronic pain stemming from underlying conditions. Not to be redundant, but these patients typically have both pain and instability. And although patients can have pain from the instability itself without any underlying issues, most often the pain is associated with an underlying acquired injury or lesion, and therefore the need for advanced imaging. I tell patients that we need to address both of their issues, both the pain and the instability, because correcting the instability cannot reverse acquired lesions and pain associated with them. Conservative treatment of lateral ankle instability is obviously more successful in cases of functional instability, but even in patients with underlying mechanical instability, it's probably a good idea to send these patients for a course of physiotherapy, which will include improving the patient's perineal reaction time, their perineal strength, proprioceptive training, modalities to ease their pain and swelling. And these are often accompanied with strategic bracing and taping and/or custom foot or ankle foot orthotics, most commonly with lateral posting. The surgery for patients with chronic lateral ankle instability is typically done via an a la carte approach with adjunctive procedures designed to address any associated underlying pathology, which may include an ankle or subtalar joint arthroscopy, an RAF of a fifth metatarsal, tendon and retinacular repairs, perineal groove deepening, calcaneal osteotomies, repair or restoration of osteochondral lesions to a full pes cavus reconstruction. This is the patient shown previously who has a supramalleolar deformity within the tibia with an underlying congruent ankle joint that was treated with a supramalleolar osteotomy. The following slides are not mine personally, but just used to demonstrate other sources of pain and pathology that may require surgical intervention. This is a patient requiring a cavus foot reconstruction, including but not limited to an Italian or Malerba-like calcaneal osteotomy. This patient had associated anterior lateral soft tissue impingement. This is an inflamed and painful Bassett's fascicle of the ATFL. The intention of this presentation was not to do a deep dive into surgical techniques, but that said, generally speaking, and for more historical purposes perhaps, surgeries have been divided into anatomic and non-anatomic repairs, wherein the anatomic repairs utilized host tissue with imbrication, with or without suture or bone anchors, in the form of a Brostrom or modified Brostrom or Brostrom Gould. Of course, there's many other iterations of this. Originally, this was described to address the ATFL alone, but in patients wherein there's a suspicion of underlying subtalar joint instability, it makes sense to repair the CFL. The surgery can be performed utilizing several different types of incisions. I prefer a curvilinear incision that starts just inferior to the tip of the fibular malleolus and courses anteriorly and superiorly. Of course, the incision can be extended or modified to address associated pathology. The mainstay of the surgery involves reefing of the ATFL in a vest over pants fashion, usually with non-absorbable suture, as well as reefing of the CFL when indicated in the same way, with the Gould modification involving the proximal advancement of the inferior extensor retinaculum. This has been the gold standard with an extremely high reproducibility and long-term patient satisfaction. The postoperative course is determined by the stabilization, the type of the stabilization, but more importantly, any adjunctive procedures that were done at the same sitting, and is largely up to the surgeon's preference. This is a schematic of the Gould. These are not my slides personally, and so this is not obviously a curvilinear incision, but another typical incisional approach with the subsequent deep exposure. Generally speaking, a trough is made within the distal fibula to enhance tendon-to-bone healing. The ATFL is then repaired using a vest over pants-like technique, excuse me, with subsequent advancement of the retinaculum. Here's a fairly old X-ray depicting suture anchors in the distal fibula. Briefly touching on non-anatomic repairs, there's virtually over 60 different procedures which have been described in the literature using different types of graft, including the peroneal tendons, the hamstring, fascia lata. This is typically and historically done for patients with more severe instability, larger patients, or patients who failed prior anatomic-like repairs. These do often carry increased patient morbidity, complications such as over-tightening. These can be technically more difficult and involve or require longer periods of convalescence on the patient's behalf postoperatively. Of course, all of this has changed rather dramatically within the last 5 or 10 years as the internal brace construct has gained extensive popularity and now is widely used. It does involve the prototypical Brostrom port of the procedure, but utilizing different suture and bone anchor constructs. Essentially, a vest or a seat belt is placed over the primary repair. This has been described as an open procedure, a semi-percutaneous procedure, and additionally an arthroscopic procedure. It has a strong, reliable construct which allows a much quicker return to sport or work. It also allows more rapid physiotherapy. And there's, of course, in the age of the internet, lots of videos and articles that one can resource to learn more about the internal brace procedure. In conclusion, chronic lateral ankle instability is subdivided into mechanical or functional types. Mechanical instability is diagnosed after positive stress use have been obtained and typically requires surgery, whereas functional instability is typically treated with a combination of bracing and physiotherapy. The gold standard for operative treatment of chronic lateral ankle instability has been the Brostrom or the Brostrom-Gould procedure, which is now widely augmented with the internal brace, which allows for a quicker return to play or work for patients. I hope this has helped. Thanks for watching.